Hi, good morning, and welcome to Grand Rounds on this chilly winter day. We're really delighted to have Larry Cytryn with us today, and I hope at this point all of you are familiar with him and all the great work that he's doing at both of our institutions. He is senior faculty in the Icahn School of Medicine at Mount Sinai, site director for the Hematology Oncology Fellowship, and director of the Sickle Cell Clinic at Mount Sinai St. Luke's. He received his Bachelor of Arts degree from Yale University in English Literature, and then his medical degree from Sickle in Israel, and then completed his internship, residency, and hematology fellowship at the formerly named Roosevelt Medical Center, very dear to all of us, and did Hematology Oncology fellowship at Lenox Hill, where he was for the early part of his career, then transferring to Stony Brook, and then on to North Bronx Hospital, where he was Division Chief of Hematology Oncology, and then to Montefiore. And throughout his entire time, I think has done wonderful work, both clinically and also in terms of his teaching excellence. And Monty, he was recognized particularly for his excellence and was as a member of the Davidoff Society for Clinical Excellence, and really helped captivate his learners around the care of patients with non-malignant hematologic disorders, most importantly sickle cell disease. And I think probably a lot of you know the Bronx is home to probably the largest population in the world of sicklers, but certainly the largest population in New York State, and has done wonderful work caring for those patients and helping us to all understand the multifaceted aspects of that important disease, including, for example, how we manage them perioperatively. It's really delightful to have you with us today, and we'll be speaking again on sickle cell, and welcome.
Thank you, Dr. Seward. That's really nice. And thank you to Dr. Lee and the other chiefs for inviting me. I was asked to tell what's new in sickle cell. I thought that actually turned out to be a good question. So although it says sickle cell disease in 2019, I'm going to try to tell you what's new, or at least some of what's new, and in doing that, I will also tell you some of what's old, or at least not so good. I have no disclosures. I'm going to mention a couple of therapies which are either off-label or not approved, and there will be several slides with numerous therapies that are experimental in one way or the other, but I won't be mentioning them. A lot of my slides use different colors. There's no intrinsic meaning. I've been asked this, so I added this to the disclosure slide. Does red mean something and green mean something else? And I mean, I guess when you're driving they do, but not this morning here. So what's new in sickle cell disease? I'm going to discuss two brief cases, and then I'll spend a while talking about the history, the definition, and the origins and epidemiology of sickle cell. And one of the reasons I'm going to do that is because there's actually something new about the origin of sickle cell, as old as that is. I'll discuss the pathophysiology of sickle cell, partly because it's understood in somewhat new ways compared to how it was understood in decades past. But also because what's new in sickle cell really relies on knowing the pathophysiology of sickle cell as it is understood today. So here are the two cases. Mr. V is 21 years old. He presented in our clinic to establish care as an adult after kind of graduating from pediatric hematology in, I think, Brooklyn. He has about 2 or 3 admissions for pain every year. He's lost, and the last one was about 10 months ago. He has 3 to 5 ER visits a year, and the last one was about 1 month ago. He's never had a stroke, but he reports having acute chest syndrome at least 10 times, if not more. And he's been transfused many times. He denies actually ever having iron overload. He takes hydroxyurea, 1,500 milligrams per day, which you should probably be aware is above the starting dose, but not a terribly high dose, sort of medium. Folic acid, naproxen, and or naproxen and oxycodone for pain, and it takes about 3 to 10 oxycodone pills a month. His vaccinations are current. He sees the eye doctor. He's had an echo, which showed normal pulmonary pressures. He works as an actor and dancer, and he's studying for his associate degree. His exam was pretty much, it was remarkable primarily for being pretty unremarkable. He was not in distress. He had mild jaundice, mild pallor. He had a systolic crescendo, decrescendo murmur, no hepatomegaly or splenomegaly, no skin ulcers, and his neuro exam was symmetric. His CBC showed a white count of 8.5. His absolute neutrophil count was 5.2. Sorry. His hemoglobin was 9.5. His MCV was 103, and his platelets were 388,000. And his hemoglobin A was 0. His hemoglobin S was 84%. F was 12%, and A2 was 4%. So this is Mr. B. Ms. S also came to establish care with us not that long ago. She had previously been followed in Brooklyn. She is 31. She has huge morbidity. She has end-stage renal disease. She's on hemodialysis. She has peripheral vascular disease. And before coming here from Nigeria a couple of years ago, she had a right lower extremity arterial bypass surgery, which was complicated and required reoperation there, and has since required operations here, including surgical repair and for infections. She has pulmonary hypertension. She has iron overload on chelation therapy. She has massive hepatomegaly. She had a DVT several years ago and was treated with finite course of anticoagulation. She takes hydroxyurea and receives EPO with dialysis. She has frequent acute on chronic pain, and she has frequent acute on chronic symptomatic anemia. Between February of last year and the end of September of last year, she had 22 ED visits and 9 admissions in our 2 institutions for a total of 65 days. She was referred to the Sickle Cell Clinic, and she presented in pain. She's cachectic, she was pale, she was not icteric, she appeared weak and chronically ill. Her hemoglobin was 6.3, her MCV was 97, her WBC was 9.9, her absolute neutrophils were 7.2, her platelets were 394,000. She felt too sick to be seen and discharged, so we wheeled her down the hallway and brought her to the emergency room where she was admitted. Reviewing her laboratory database, we see that her hemoglobin A's vary between 50 and 86%. Her hemoglobin S's vary between 6 and 41%. Her hemoglobin F varies between 0 and 4.6%. And her hemoglobin A2 varies very little between 2.5 and 3.7%. So these are 2 patients. I'm going to spend the next while talking about the history, the definition of the origins of the path, and the epidemiology of sickle cell. So the earliest reports, as I understand it, in my reading for this talk, come from Africa. It was described in the 1870s, and it was known in some areas as Obanjis, which means children who come and go. I can tell you there are other tribal language names for this disease, almost all of which are onomatopoetic, and I didn't include this slide. Making the sound of somebody moaning in pain. And the reports, one of the reports refers to a family from Ghana going back at least to 1670 known to have this disease. In the United States, the history began in 1904 when Walter Clement Noel, who was a dental student from Grenada, studying in Chicago, went to see his physician because of anemia and pain at the University of Chicago. His intern was Ernest Irons, and his attending was James Herrick. And in caring for him, they observed under the microscope, published, and named the sickle-shaped red cells that characterize the disease. And in 1949, Linus Pauling identified this as the first identified molecular disease. So this is a disease of the molecule hemoglobin. Definition, I think, is this is a reasonable definition. It's a disease that results from an inherited mutation of the beta globin gene. It results in the polymerization of hemoglobin in a deoxygenated environment. The red blood cells can form shapes resembling sickles. This shape change results in anemia from hemolysis and basal occlusion, results in pain, organ damage, morbidity, and mortality. This has been the kind of definition and description of sickle cell for a long time. But as you're going to see in the next few minutes, this is really not the whole story. In trying to understand the molecular basis of the disease, people with the sickle, the hemoglobin S mutation, had their genes analyzed. This was before DNA sequencing was easy and common. And so with restriction fragment enzyme polymorphism studies, this panel of restriction enzymes was used and digested the DNA of hundreds of patients with hemoglobin S, whether they had sickle trait, SS, or S beta thalassemia, or SC disease. And it was found that no matter who they were and what kind of disease they had, their hemoglobin S allele was 1 out of 5 possible polymorphism patterns. So every hemoglobin S mutation was associated physically with 1 of 5 different gene sequences or nucleotide sequences, and they were localizable geographically. So the 5 sequences were named for the areas in which they were prevalent: Senegal, Benin, Cameroon, which is a very small in area and small in number, haplotype. These are called haplotypes. This was called Bantu. This is one of the original illustrations. It's now called Central African Republic, CAR, and Arab India. And this led to the conclusion that sickle cell developed independently 5 different places in this region from 5 different single founding mutations of the exact same beta-6 glutamyl, which I'm going to show you in a minute. So the first thing I'm going to tell you that's new is last year, DNA from, I think, 1,000 people with the hemoglobin S mutation was analyzed with current technology. And it was found that prior to 5 haplotypes, there was a single founding mutation, a single individual, which I think is amazing. I can't read this paper critically, but the idea of this is amazing. This mutation occurred probably in sub-Saharan Africa, but maybe slightly west of there, when this occurred 259 generations ago. I'm speechless just saying these things, and corresponding to 7,300 years ago. And I'll get back to that in a minute too. But this was a time when the Sahara was not a desert. It was a savanna with trees and grass and rain and standing water. This is why we owe sickle cell in a lot of ways to this. So this is Anopheles, and inside Anopheles is falciparum malaria. So Anopheles and falciparum, they've been around, this is also pretty amazing to me, I think, for more than 100 million years, according to fossils. But really, 3,000 to 10,000 years ago, they really became stars in our lives, and that was because we settled down and stopped being hunter-gatherers and started having agriculture societies with standing water in temperate climates or subtropical climates. And the first description of malaria apparently was written in China about 4,700 years ago, and the first in Europe was written about 2,400 years ago by Hippocrates, and the Romans knew about it, and wherever they conquered and settled, they dragged the swamps. So this is a picture of where malaria is, or falciparum malaria is prevalent. And you can see, if you just keep this picture in your mind's eye for a second after I move on, that it's almost superimposable with this picture. And this is a picture of the hemoglobinopathies and where they're prevalent. And you can see sickle cell and thalassemia and hemoglobin C over here, D and E. And if you wanted to, you could add G6PD deficiency as well. And all of these protect against not malaria as an infection, but malaria as a lethality. People who get infected with malaria are less likely to die if they have one of these hemoglobinopathies. And this slide until just now, because when I've been working on it, it just appeared. But anyway, this is from Dr. Ballin at Mount Sinai, Brooklyn. I include this because you can see in this image how really completely superimposable these two phenomena are. So in the United States, standing water in about 110 people of African ancestry, give or take. In West Africa, the prevalence can be as high as 40%. Sickle cell anemia, which is defined, at least in our lexicon here in the United States, as SS disease, occurs in about 1 out of every 600 African Americans, maybe somewhat more than that, maybe 1 in every 400 and change to 500 African Americans have sickle cell anemia. And because we're on the East Coast, it's prevalent in Latinos as well, which is probably more so by a significant amount than it would be on the West Coast. And that's because of the African influence greater among Latinos on the East Coast to the point where it's about 1 in 1,200 Latin Americans, Latino Americans on the East Coast. SC and S beta thal are less common but not rare. So this comes out to be 90 to 100,000 people in the United States affected by the disease, sickle cell disease. But to put this in context, every year in Nigeria alone, 150,000 babies are born with the disease. So it's orders of magnitude more prevalent and orders of magnitude more catastrophic, I guess, in other places in the world than what we appreciate here. Sickle cell disease-related mortality in Africa remains high. This is from 2011. I think originally it's from the World Health Organization. It can be in certain areas as high as 50 to 90%. I'm going to get back to that at the end when we do start to talk again about what's new. In order to know what's new in sickle cell, really, I think the pathophysiology has to be kind of looked at a little bit more in depth. And so for the next few minutes, I'm going to go through that. And then in the last part of the talk, we're going to talk about what's new related to each step of the pathophysiology that I'm going to look at briefly now. So it's a disease of hemoglobin. This is hemoglobin A. Hemoglobin A inside the red cell, which is not the same as the way it behaves when it's free in the plasma, but inside the red cell, hemoglobin A is a tetramer with 2 alpha globin chains, 2 beta globin chains, and each chain containing 1 heme group with iron, which binds oxygen. Hemoglobin comes from 2 genes on 2 different chromosomes. The beta globin gene cluster comes from chromosome 11 near the top of the small arm. Control 1 and 2 region in red. This controls which of these, which are the genes, is expressed and when. This is, by the way, the site of the 60 or 100 or 200 mutations causing beta thalassemia. This is epsilon for the first few weeks of embryonic life. This is the beta-like globin, which combines with zeta, which is the alpha globin-like globin, which I'll talk about in a minute. These are the 2 fetal globins, beta-like globins, they're gamma, and this is the final mature beta globin. They combine with alpha globin, which is for the gene for which is on chromosome 16. Zeta is the counterpart to epsilon. These are expressed just for a few weeks until fetal hemoglobin is expressed. And I'm going into this detail for a reason, because we're going to want to know about fetal hemoglobin several times during the rest of the hour. And fetal hemoglobin requires alpha globin and gamma globin. So this is, I showed you a minute ago, hemoglobin A. That's what we have in our adult red blood cells. And by adult, I mean by the time we're 6 months old or so. And this is hemoglobin F, and you can see they share the alpha globin gene, the alpha globin proteins on the bottom, but they differ with the gamma globin proteins on top. These 2 are 2 different colors because the 2 gamma proteins differ by a single amino acid. They're not completely identical. And just to remind us, alpha is necessary in the fetus. Alpha globin is necessary in the fetus to make hemoglobin F, but beta globin doesn't really get expressed until afterwards, as I show you in this picture. Here, I'll go back to that in a second. On the x-axis is time from conception over on the left to birth in the middle. And on the y-axis are 100 of hemoglobin inside our red cells. So if we ignore the very far left, which is embryonic and which disappears in favor of hemoglobin F, fetal hemoglobin. Fetal hemoglobin is the prevalent hemoglobin in our red cells throughout fetal life. And fetal is good because it is better at holding on to oxygen than mother's hemoglobin A. And so mother's hemoglobin A comes to the placenta, baby's hemoglobin F comes to the placenta, and the F preferentially carries away oxygen. So that's great. We're born over here, and we're born here, and you can see 80% of our hemoglobin is F. But by 2 months, it's about 50-50, and by 6 months, it's about nothing. All A. Which means somebody with a beta globin disease is going to start to get sick in here, but is not sick in utero. I put this here because what I really want to show you now is this version of the same thing. This is a tetramer as well, and I put this version up because of what I'm going to show you next, which is meant to show the change in shape of this molecule. And this molecule, which is our hemoglobin A tetramer, changes shape between the time it's in the lung, when it's in an oxygenated environment, and the time it goes out into the tissues and it's in a deoxygenated environment. And what happens is, in the lung, and this is really a cartoon version of this, in the lung it opens up so that each successive oxygen entering hemoglobin enters more easily. And this is called the relaxed state. This is called increased affinity. And so oxygen comes into the tetramer easily. It goes out into the periphery, oxygen comes off, and as this is a positive feedback loop, making greater affinity with each successive oxygen, this is a positive feedback loop in the opposite direction, so that with each oxygen unloading, the affinity becomes less. It kind of tightens and squeezes out each successive oxygen. This is important because when this change in shape occurs, a couple of things happen. So this is yet another cartoon of this because it's going to show us why people with sickle cell get sick. So here's the oxygenated tetramer. It's bright red. It's in the lung. It's happy. We're happy. It goes out into the tissue. It unloads oxygen. And this little pocket now is exposed because of that shape change. This pocket wasn't exposed in the lung, but it's exposed in the periphery. Also not a problem unless a person has a valine in the 6th amino acid position. And this valine and this pocket interact. And so this pocket from this beta globin interact with this valine from a neighboring beta globin, and suddenly this kind of filament forms, which is not the polymer yet. This is the polymer where 7, or actually 14 of these form. I guess it's 7 of these form, and form a polymer. So this polymer is not a trivial structure, and this polymer can form quickly. This polymer can form in seconds, sometimes as slowly as tens of seconds, and sometimes as quickly as tenths of seconds. And they form inside of the red cell, and so here's a picture. I'm not looking at the left, but I'm looking at the center and the right. These are photographs, and to me these are really impressive because this should be, the red cell should be a smushy little thing that can squeeze in and out of very small spaces, and you can imagine that this can't do that. Not only that, but you can imagine that when this happens, this is a red cell too, when this happens inside a red cell, you can imagine there's incredible damage to whatever structures are in there. So if this room were a red cell and this happened to us all of a sudden now, the computer would be destroyed, the screen would be destroyed, we would have to duck, cover, the window back there where the AV people are would be destroyed. This would be a mess. And this happens almost every single time a red cell traverses the circulation. So in recent years, I'm going to start to come to what's new. The physiology of this disease has really kind of become elucidated a little bit better, and one had to do with the observation about 10 years ago that even though everybody, I mean, it was always known that everybody has the same mutation, and individuals have very variably different diseases, even though they all share the same founding, underlying mutation. So it became apparent that if we tried, we could kind of separate the phenotypes, and they kind of, although they're in a spectrum, kind of segregate a little bit into kind of a hemolytic phenotype and a vaso-occlusive phenotype. So these people with this kind of phenotype have more anemia, their hemoglobins are lower, they hemolyze more, so that we see evidence of that in blood testing. We can see plasma-free hemoglobin, high retics, high LDH, high bilirubin, and their complications tend to concentrate among pulmonary hypertension, leg ulcers, priapism, and stroke. People on this end of the phenotypic spectrum tend to have higher hemoglobins, they have lower retics, so they're hemolyzing less. There is more nitric oxide bioavailability. I should mention that over here, the scavenging of nitric oxide by free hemoglobin, which occurs as a kind of consequence of hemolysis, and so occurs more in people who have more hemolysis, seems to be closely associated with pulmonary hypertension and other vasculopathy in sickle cell. Whereas here, with less hemolysis, there seem to be less of those complications, but rather more complications due to viscosity, vaso-occlusion, such as avascular necrosis, acute chest syndrome, and pain. Well, this is a kind of a really simplified, it's a cartoon, a really simplified kind of conceptual framework of pathophysiology as it's looked at today. And we can start almost anywhere here, but let's start here with the beta globin gene mutation, which I've described. Instead of an A, there's a T, so instead of a glutamic acid, there's going to be a valine. That's technically, in this cartoon, not in here because there's no nucleus in here, but the resultant protein product is in here. The damage that I just kind of imagined happening to us here inside of a red blood cell damages the membrane and results in significant loss of potassium and water from red cells, so they become dehydrated, which, by the way, facilitates the polymerization of the hemoglobin. When I said it could be from tenths of seconds up to tens of seconds, the relationship is to the concentration of hemoglobin S in the red cell is extreme. So when hemoglobin S concentration of red cells goes up, the rate at which polymerization occurs goes up a lot. Polymerization occurs, and so the change in shape of, the change in oxygen affinity occurs, and so polymerization occurs because of the change in shape of the tetramer. There is, and this was sort of an observation that wasn't obviously predictable, there is a great deal more adhesion of red cells, but also platelets and white cells to blood vessel endothelium and also to each other compared to normal, and more in damaged red cells than in healthy red cells. Because of hemolysis, there is more nitric oxide consumption, there is more oxidative stress, and each of these sites, mutation, polymerization, dehydration, adhesion, inflammation, and oxidative injury, are targets of therapy that are either about to be available, are available, or at least may be available in the foreseeable future. So that's what we're going to talk about now. In order to start to talk about that, though, we need to go back to hemoglobin F and because we need to start with hydroxyurea. So on the left is a picture of the red blood cells in an oxygenated environment, hemoglobin S containing their nice little pink spheres. They go out to a deoxygenated environment, they change shape, they polymerize. Toward the right half, the same thing is happening in the presence of a lot of hemoglobin F, and by a lot, meaning, I don't know, 10% of the hemoglobin molecules, 15%, that's a lot. So the hemoglobin F molecules are yellow colored and cubic in shape in this illustration, and you can see that they do interact and bind with the hemoglobin S tetramers, which are round and pink, just like they were over there. But now you can see that when they become deoxygenated, the presence of S is not sufficient to cause polymerization because the presence of F, these now blue cubes, get in the way. And they get in the way physically, and they get it away electrically. So the presence of F is good. More F is better than less F. And that's the basis for using hydroxyurea. This trial ended 23 years ago. Hydroxyurea was used because it was an oral agent. It was easy to give and easy to take, and it was known from prior work in leukemia and related disorders that it induces hemoglobin F. And in the 150-ish people given hydroxyurea versus the 150-ish people given placebo, the rate of crisis was about half, approximately. The time to the first crisis was about double. The time to the second crisis was about double. And probably, at least to my way of thinking, the most important thing was the incidence of acute chest syndrome, which is the diagnosis most common, as a most common cause of death in individuals with sickle cell disease, also was reduced by a factor of about half. So the hydroxyurea seems to reduce disease and complications by about a factor of 2. That was 1995. 9 years later, it was published and it seemed to be resolved. The study was terminated early because there was a clear benefit to the treatment arm. And all the people in the study were continued to follow and remain followed up to this day. And at 9 years, it was starting to appear that survival was improved in those people who got hydroxyurea, who were taking it compared to those who weren't. Because at each follow-up, it was indicated, because now everybody was encouraged to take it, it was indicated as far as whether individuals, in fact, were or were not taking it. And the same thing was observed at 17 and a half years. Mortality was reduced in individuals with long-term exposure. And by that, they meant at every 3-month interval, the person would be graded as to whether they take hydroxyurea or not, and if so, do they take it half the time, more than half the time, all the time. And the greater the exposure to hydroxyurea, the greater the survival benefit. But a mean survival was never published. The reason I mention that is I haven't seen, this is 8 years ago now, 9 years ago, I haven't seen further follow-up, and I may have missed it, and I looked, and I may just fail to find it, but I haven't seen it. What I did see is this, and I'm going to talk about the paper that this was attached to in a minute, but this was a letter based on a paper that I'm going to show you on the treatment of sickle cell with glutamine. And this letter included data from the NIS, the National Inpatient Sample, and it showed something which I've heard from, there have been actually other reports, observing that there is not a survival benefit with hydroxyurea. So I don't know the answer, although I think there probably is, because of the methodology of those papers that show there is better than the methodology of those papers that question. Anyway, this is from the National Inpatient Sample, and you can see that from the year 2000 to 2014, the number of hospitalizations for sickle cell increased, the mean cost increased, even though hydroxyurea is not a particularly expensive intervention, and the rate of death seemed to be the same. So this is really, I think, it remains something of an open question. However, 3-4 years ago, a 150-page monograph written by several, probably a dozen authors over a period of several years or more, reviewing the entire clinical literature on sickle cell and evaluating it as evidence, and then asking questions to see whether that literature, whether that data can answer those questions, and then indicating the answers to those questions and grading them as far as whether they are evidence-based recommendations or not, came to several important conclusions, and that one of them was that hydroxyurea should be offered to almost everybody with sickle cell disease. Anyway, I recommend this. It's very intelligent. It's evidence-based. It's user-friendly. Internally, it's kind of electronic, so you can jump from one place to another using a mouse. This is a tenth of the length, written by the same authors, published simultaneously, and this just includes the recommendations themselves without much discussion as a kind of shorthand version of the first publication. But beyond hydroxyurea, last year, and now formally this year, the American Society of Hematology has kind of enthusiastically and formally adopted a sickle cell initiative. The meeting was last month. This is very current. This is less than 6 weeks old. Where last month, 25,000 attendees were at this meeting. And the Sickle Cell Initiative, created, I guess, by the American Society of Hematology, includes a number of different arms. So they are pushing very strongly the increased use of hydroxyurea. There is a patient's disease coalition. There are research priorities and policies. There are policy priorities. There are global initiatives, access to care initiative. And two of the papers, of the many, many papers at the meeting, I thought I would present to you. This paper was one of the plenary session papers. Plenary session means that they select a couple of thousand abstracts to present in one session. And this paper was reporting on the assessment of the feasibility, safety, and benefits of hydroxyurea in sub-Saharan Africa. So, as I mentioned to you, sub-Saharan Africa, the prevalence of sickle cell is very high, and the penetrance of therapy is very low for all reasons. So they enrolled 635 children, almost complete adherence and follow-up, which was really impressive. And what they found, I don't want to read the whole thing, but I put it here so that I would. The benefits of hydroxyurea included clinically significant increases in hemoglobin concentration, MCV, fetal hemoglobin, which are good markers for adherence and effectiveness based on 25 years of experience. Significant decreases in WBC, neutrophils, and retics, which is to be expected. Clinical benefit were also observed as vaso-occlusive pain, acute chest, transfusions all decreased about 50%, which is what was seen 25 years ago in the original hydroxyurea trial. Unexpectedly, the rate and severity of malaria also decreased. Malaria declined from 48 to 22 events per 100 patient years. Clinically severe malaria fell from 10 to 2.5 per 100 patient years. So this was a surprise. I don't know the explanation for this, but it's good. And so this is really not only an accomplishment, but it's a proof that this can be accomplished. Similarly, this was among the so-called late-breaking abstracts. So in the very last morning of the conference, they show a couple of abstracts that came in too late to be included in all the other sessions. And this demonstrates a test. And this test was used in 4 centers, I think, in southeastern Uganda. It is cheap and fast and doesn't require much technology and is much faster and much cheaper than the standard test for making the diagnosis of sickle cell. And not only that, but it's not influenced by hemoglobin F, which means a newborn can be tested with this and be diagnosed with sickle cell before she leaves the hospital. And although many babies aren't born in the hospital, many babies are. And this test can be transported outside hospital settings. So, and to know that a baby has sickle cell disease is important because a lot of preventive care can be given and in the hope of improving infant survival. So going back to this picture, I'm going to talk about a couple of different interventions that reflect these sites of pathophysiology. When I started to put this together, and this was kind of where I was hoping to wind up, I had this, you know the movie A Few Good Men, you know, Jack Nicholson? I felt like this was talking to me and saying, you want to know what's new in sickle cell? You can't handle what's new in sickle cell. And I'll show you why. This is why. The next, I think, 9 slides come from a review that came out a couple of months ago about what interventions have been, and soon will be evaluated, whether it was in mice, whether it was in humans 15 years ago. Most of these are current or future. And many of these have not even been done in humans yet. Some of them have and failed. Some of them haven't succeeded. This is kind of a summary. And so I'm not putting these up for you to look at these. These are hemoglobin F inducers and anti-sickling agents. By the way, metformin is an interesting story down there. Anti-sickling agents. Clotrimazole is on this list, by the way. Ischemia reperfusion modulators and interventions for to reduce oxidative stress and inflammation. One of these, I think, we're going to talk about, which is glutamine. Anti-inflammatory agents, antiplatelet therapies, antithrombotic therapies, agents that counteract free hemoglobin, anti-adhesive agents, and we'll talk about one of these. Organ-specific therapies, especially targeting the lung and the kidneys. So, using this platform, I'm going to spend the last few minutes of the talk talking about a couple of things that are actually new. And this is a brief list of those. I'm going to talk about crizanlizumab, oxelidor, and glutamine, and CRISPR at the very end, just as a kind of shout out. So crizanlizumab is a T-selectin inhibitor, so it's going to act at the level of adhesion. And as it turns out, and I didn't bring these slides because it would have added too much time, I think, adhesion is probably the single initiating pathophysiology of a vaso-occlusive event. Adhesion of reticulocytes to endothelium, adhesion of white cells to endothelium, adhesion of platelet and white cells to red cells. All of this, it's like traffic. All of this slows down traffic. And when traffic is slow, red cells have more time in a deoxygenated environment, that is, to polymerize, to have their hemoglobin polymerize. So to inhibit adhesion might have benefit, and this treatment, which is given intravenously monthly, although it is a loading period at the very beginning, reduced in 200 patients, reduced by about, I don't know, half to a third the rate of vaso-occlusive events. The time to first crisis increased by a similar proportion, and the time to second crisis also increased by a similar proportion. So this is in the same order of magnitude as the effect clinically of hydroxyurea, but by a completely separate mechanism. And hemoglobin F, as I recall, didn't change, by the way. This is not approved yet. I think it is expected that it will be. This was published about 2 years ago. Glutamine is an amino acid which was used in this trial because it was known to increase the energetics of red blood cells. It increases the ratio of NADH to NAD, if I remember right. Was used in about 230 patients, randomized 2-to-1 treatment to placebo, and it reduced by about a third the incidence and frequency of pain, the number of hospitalizations per follow-up, which was 48 weeks, a year-ish, and sorry, not total, but 2/3 of both groups took hydroxyurea at the same time. So in a sense, similar to the first paper, this trial indicates that this treatment has benefit and can be given in addition to the standard therapy of hydroxyurea. There were 2 deaths in this paper, both in the glutamine group. It was felt that they died for medical reasons unrelated to the intervention. And this is currently approved. It's expensive. And I will tell you that there's a sort of a caveat. This drug was used in critically ill patients a few years ago in a randomized controlled trial, and the patients receiving the intervention had worse survival, greater mortality, so the trial was stopped. It doesn't appear that whatever happened there is reproduced in whatever happened here with patients with sickle cell disease, but when we talk about this with our patients, we discuss this in detail and make sure they understand this. And we follow them more closely than we would otherwise, and we follow their renal and liver function more closely than we would otherwise. This medication, GBT440, called oxelidor, this to me is a very interesting idea. This little molecule is going to keep the hemoglobin tetramer from changing shape. It's going to come into the lungs. The tetramer is going to come into the lungs inside the red cell, the hemoglobin, It's going to open up and receive oxygen, and then it's going to keep that shape because of this molecule. So when it goes out into the periphery, it's not going to start assuming the tense conformation. Now you might say, well, if that happens, how's it going to offload the oxygen? And that's an issue. Doesn't seem to be a clinically relevant issue because they sort of target the dose to affect about 30% of the red cells. So I don't know the biology of this, and I don't know whether, as it seems, it's the other 70% that provide the oxygen to the tissues, and this 30% help derive clinical benefit for the purposes of not polymerizing hemoglobin S. But in any case, it was found, this was also presented a month ago, that hemoglobin increased. And this was a phase 1-2 trial, and even though it was placebo-controlled, and the outcomes were whether this increased hemoglobin and decreased hemolysis, and the answer to both of those were yes. So it's going to be in phase 3 trials as far as disease-modifying effect. Sickle cell disease can be cured. It can be cured by allogeneic stem cell transplantation, which means, and this was known, this is a paper from 20 years ago. It was almost 25, that if you get rid of somebody's bone marrow and give them somebody else's bone marrow who doesn't have sickle cell disease, they won't have sickle cell disease anymore. There are 2 caveats. Number 1 is about 10% mortality. And number 2, about 20% of people who have the disease sickle cell have an HLA-matched donor. So this doesn't really apply very widely. But what if we could give somebody a stem cell transplant with a haplo-identical donor, meaning sharing only one of the 2 HLA alleles, meaning almost everybody has such a donor. Everybody's parent is haplo-identical to them. And 75% of everybody's siblings, and at least half of their half-siblings, not at least half of their half-siblings, will be haplo-identical, which raises the possibility that almost everybody with the disease will have will have a donor. The catch is this is a more difficult transplant, and about half of the time it either doesn't engraft or gets rejected, the graft gets rejected. So about half of the time the person undergoes a transplant, a little more than half actually, undergoes a transplant and winds up with their own hematopoiesis at the end of the day, or at the end of the month, or whatever. So it fails. Gene therapy. You take a person's own bone marrow and fix their gene. Now, it's hard to fix a person's gene and get it expressed, meaning putting in the correct gene, the normal gene, and getting it expressed in sufficient amount. That eventually, I guess, will probably happen, but it hasn't happened yet. But what can be done is it can be a gene for expressing hemoglobin F can be inserted. And as we saw, if you can increase somebody's hemoglobin F from 10% to 22%, you can ameliorate their disease tremendously. So gene therapy is happening. This is a paper describing the experience in a human who was treated in France and who was successfully treated with a hemoglobin F expressing inserted gene. And finally, CRISPR, very famous. CRISPR is a way to target a DNA correction. And so you can either target the mutant thymine and replace it with an adenine the way it's supposed to be, or you can introduce a hemoglobin F producing sequence into a patient's gene, give them back their own stem cells. It's not a transplant. You don't have to, bring them close to death to do this, and have them leave with a gene which is different than the one they wanted. So to bring us back to our patients and to bring us to the end of the talk, Mr. V, we looked at his ANC. You might have noticed, and his MCV was a little bit high, but not very, and his ANC was normal. So we talked about whether maybe is he taking the medication every day, and it turns out no, he's taking it maybe half the time. And he's very knowledgeable, and we talked about ways that we could maybe improve his appearance, and he was interested in trying this because he has no specific objection to taking it daily. And we discussed the possibility of adding L-glutamine. We gave him some literature, and he's going to look into it further. Miss S. Now, we talked about new stuff, but we also talked about old stuff. And with Miss S, we began trying to keep her out of the hospital. That was our main goal, and the way we thought we should do that, at least in the beginning, is to transfuse her. And because she's on outpatient hemodialysis, there are issues of volume, and because the hemodialysis centers cannot transfuse her, the outpatient centers can't transfuse her, we're bringing her in every week for a unit of red cells. Some weeks, on occasion, 2. Some weeks we actually haven't had to transfuse her, and hopefully we may even be able to stretch that to 2 weekly visits. And the other thing we're doing is we're prescribing her opiates weekly, so that if she does run out early, which we encourage her not to do, it won't be days and days early, but she'll know that if she can manage another day, she can come in and be seen on schedule, and maybe we can eventually get her on lower doses of opiates and fewer ED and hospital visits. And since the end of November, since the end of September, she hasn't had any ED visits. She had one admission, which was infected right lower extremity stent, which required surgical correction, and we'll be seeing her today, actually. Thank you.
Thank you very much. It's a really wonderful process, wonderful gift to get so much people about the pathophysiology. 2 questions for you. You commented briefly on transitions from pediatric to adult care, and I wondered if you might elaborate on that a little bit. What patients tell you they experience as the most important barriers from one setting to the other. And then relatedly, in terms of the new therapy, in your mind, what are the most important patient-reported outcomes that we have to pay attention to? I assume it's related to pain, but just would be curious to hear about that as well.
We often don't get to see pediatric patients when they graduate pediatrics. I think there are a lot of small reasons that compound into a single failure. I think a lot of it is, logistical. A lot of it is habit and the psychological attachment to habit and fear, where they'll no longer be treated as children. I think even with the best of intentions, we treat our patients fundamentally differently than they get treated in pediatrics. And I think even without realizing that we do it, we may create an environment which is frightening and less friendly and not nurturing. But what I find is that it's hard for us to even have the patient arrive for the first visit. And so I think it's scheduling and logistics. I think that's part of it. The second question, the outcomes that we should be looking for, well, it depends on the patient. I mean, for Miss S, the outcome I'm looking for is that she shouldn't have spent such a huge amount of time in the hospital and emergency room. How can we stop that? How do we interrupt that cycle? And I think for her, it's by making it very outpatient intensive and to support her red cells. If it's a person who has a job and a family, it may be, higher hemoglobin, more energy. Depends. We'd have to ask them what their, since you're asking what a patient-reported outcome, I would ask the patient what outcome is important to them. Mostly it's pain. And in some patients, it's pain and to reduce their opiate requirement. But that's up to them.
Thank you. That's superb.
Ah,
I really enjoyed it.
That's very sweet. Thank you.
But we have such a rich history here, actually, 10 years. And
Yes.
to answer one of those questions, if we have a sickle cell clinic, one of my daughter's brother is one of the great innovators in sickle cell care, in which case they're not in the transition. They do all children and the adults. So in one place, one team, and including all age groups. So they had a tremendously successful management of these patients. The other is that Dr. Bertels was the chief of hematology years ago, major contributions in looking at the differences between sickle cell disease expression in different climates, which seems to make a difference. The question I want to really ask is part of the problem for these patients is they are so psychologically traumatized by the disbelief of their pain complaints. And they're often accused of seeking drugs instead of healing. And this rage and anger of this disbelief plays a role. And there are always a few bad characters really well. So I'm sure there are some who do this, but the majority don't. And when I talk to these patients and ask them about their experience in the hospital, that is the most common. So do you have any way of dealing with this? Because, thank goodness, the pain issue is being taken out of patient experience surveys, because it turns out that number one, it's impossible to measure accurately. And number two, it is always good pain. There's such distance people have to do that. But so is there a way that you can help us to train people to deal with these people in a more humane way so they're not referring they're traumatized?
Thanks for the question. That's an important and interesting question, and a hard question, and I don't have an answer. The short answer is I don't know. But I can give you a long answer. There's a couple of aspects to what you've asked that I have thought about for many years. First of all, I believe almost everybody. I think it takes a lot, and in fact, I almost have this as a formal rule internally. It takes a lot for me to not believe somebody. So if they tell me, and there's no test, that should be understood. There is no test that we can do to find out if somebody's in pain, to find out how much pain, and to find out if they're in more pain today than yesterday. It is very unusual for me to reach the point where I can't believe what the patient is telling me. And if that's the case, then that's the case, but that's rare. And it's much easier, I think, for me to live my life believing people, and for me to live my life believing patients, and for me to take care of patients by believing them. And unless I have really good evidence to the contrary, if they tell me they're in pain and they need this medicine, I will do that. I'll prescribe it for most people. People who get high doses of opiates, I find, are a sort of a separate, although clearly related, group of people with group problems. And I think of those into two groups of people. One is people who are group of people who are functioning. They pick up their kids from school. They run a home, or they have a job, or they go to school. And if they're on a ton of opiates, but they're functioning, and they say they're functioning, and they're not coming to the ER, and they're not being admitted, okay. I don't have to reinvent their care the way 40 doctors before me have tried to reinvent their care. But if somebody is on a lot of opiates, and they're in the ER a lot, and they're telling me they're in pain all the time, and they're hospitalized a lot, then whatever we might agree or disagree on, we can agree that their opiate regimen is not working very well. My experience with the pain service here has been great. I think they are responsive and thoughtful and respectful of our patients. At least that's been my impression. And so I rely on them to give good advice, and I try to follow their advice. If they can tell me that I should change this or not change that, then I'll generally try to do that. But if somebody has, 95 days in the hospital and has been to the ER 18 times in the last 12 months, then something isn't working. So I try to reason with that person. The other thing is I try to medically try to optimize whatever can be optimized. Where is the pain? Why is the pain? Does a person need a hip replacement? Does a person have, need an injection into their cervical spine? There are reasons that actually can be treated. We found somebody who probably has an autoimmune disease and has inflammatory pain and not particularly sickle cell pain. So it's worth looking. The simplest thing for me, just to keep my life simple and to do no harm and hopefully to do some good, is I try to believe people. So that's the answer to your question.
Question down now.
Oh, okay.
Question from Mount Sinai West over here.
Yes.
I have a question from Mount Sinai West. Since the patients with sickle cell are managed and they are reaching adult life and living a lot longer, have you seen secondary malignancies and specifically hematological malignancies that you see in the myeloproliferative as a result of this heavy exposure? And after that, I just have one comment. This week's New England Journal features the report we alluded to on the experience of hydroxyurea in Africa. It's the lead article in this week's New England Journal.
So thank you. And the first answer is no, but there's a little asterisk to that no. So far, it has been looked for and not observed as to an increase. I didn't say this very well, but there has not been an observed increase in hematologic or other malignancies in patients with sickle cell disease receiving hydroxyurea. Now, as far as globally, patients with sickle cell, I don't mean globally, literally, I mean as far as generally speaking, patients with sickle cell and secondary malignancies, to my knowledge, that also has not been observed. But the real careful inspection has been on patients with on hydroxyurea, because in patients with myeloproliferative neoplasia, there's some information indicating that in some groups of patients, hydroxyurea does increase the rate of secondary malignancy, if I'm right, and I think I am, and in particular, people with essential thrombocythemia. People with polycythemia vera, I think, in fact, the numbers do not reach statistical significance, and so it cannot be concluded that the rate of increase, the rate of acute leukemia is greater in people with polycythemia vera treated with hydroxyurea. But I think it actually is slightly in patients with ET. So that's on the table in patients who already have hematologic or hematopoietic disease. Sickle cell biologically doesn't seem to be related to patients to myeloproliferative neoplasia. So it's not counterintuitive that they don't seem to get more hematologic malignant disease. Saying that is based on what I'm, at least to the degree that I'm familiar with what's been published. But I do know of a number of people who care for patients with sickle cell disease who have observed erythroleukemia in a patient, each with a separate patient with erythroleukemia, and that at least makes you wonder. But no, it doesn't seem to be the case that because of exposure to hydroxyurea or because of the nature of their underlying disease that it does not seem that they get secondary malignancies more commonly than anybody else.
How do you then go counseling for pregnancy in sickle cell women?
Well, if you mean how do I talk to them before they're pregnant about becoming pregnant, I tell them that pregnancy makes sickle cell more dangerous and sickle cell makes pregnancy more dangerous, but women with sickle cell get pregnant and they have babies and we help them. And, if it comes to prenatal testing, I'm not even sure I understand why the question gets asked, and I just don't think it's something that you do for sickle cell related pregnancy or I think it's good to know whether your partner has the trait or not, or whether there's a risk for sickle cell in the baby. But if in the mother, we try to have them visit very often. Originally, there was work from a randomized trial from a long time ago that showed that preventively transfusing pregnant women did not improve maternal and fetal outcomes, but did reduce complications. But more recent work, I think, then analyzed as part of a large meta-analysis, kind of landed on the side of certain women probably would benefit from transfusion during pregnancy simply because they're pregnant and have sickle cell. And so anybody who has had a severe phenotype, we do actually transfuse, especially later in the pregnancy, try to keep their hemoglobins above something like 7 or 8. And we try to communicate reasonably carefully with the obstetricians. And we see them frequently.
Thank you very much.
Sure.